I know we're competing with lunch today, so I appreciate you being here. These are the financial disclosures of the group. So my presentation is entitled Difficult Conversations. As you know, chronic non-infectious uveitis often requires systemic steroid-sparing immunosuppression to prevent inflammation and or corticosteroid-induced complications for the patient with vision loss. And sometimes this fact can be very difficult for families. Why is the diagnosis and treatment so challenging for families? And part of it is just a lack of familiarity with uveitis prior to the diagnosis. Everybody's heard of diabetes, everybody's heard of ADHD, but uveitis is kind of a foreign, something that they've never heard of before. And then also finding out that your child has a chronic disease without a known cure, without a known timeline is unsettling. And on the same lines of familiarity, there are also feelings of isolation. Family and friends are unfamiliar with the diagnosis, so you're constantly trying to explain the diagnosis. And then one of the biggest things is that the child is asymptomatic many times, and the parents can't see the disease. They may be 20/20 at this time, and so how can something that has no symptoms warrant the risk of immunosuppressive therapy? Facebook and some blogs perpetuate misinformation, and compounding that is the burden of missed work in school for frequent appointments. So I'm going to present one case that occurred recently. This is a 4-year-old Caucasian girl who presented with anisocoria, found to have bilateral chronic anterior uveitis. Her best-corrected visual acuity was 20/25 in each eye, and in addition to inflammation in both eyes, she had complications at baseline, which included band keratopathy, synechiae in the right eye, and papulitis in the right eye. Her laboratory evaluation and chest x-ray were unremarkable. She was referred early in the course to rheumatology, and no systemic diagnosis was found. And immunomodulatory therapy was discussed early in the course by both the rheumatologist and myself. She improved on predacetate and cycloplegic agent, but we were unable to taper to less than 3 drops of predacetate without recurrence of inflammation. And in the meantime, she developed steroid-induced ocular hypertension. And so at this point, we recommended methotrexate. The next appointment, Dad comes in ready for battle. And I don't know if you've heard this before, but he said, "I can't believe you want to put my beautiful little 4-year-old on chemotherapy that my wife, who is pregnant with twins, can't even administer." He was belligerent, very angry. I maintained my composure and kind of went through the reason why we were doing it. But it was a little confusing. Hadn't we discussed systemic therapy all along? And later, once the dad had a chance to kind of cool down, he gave us a little insight that when he went to rheumatology, they didn't find a systemic association. He pretty much walked out of the room thinking, "Glad we're not going to need this stuff." They appreciated the consultation, but they didn't think it applied to them. And then Mom chimes in with her literature review of Google, and that methotrexate causes kids to be sick for the entire weekend. Yes, it can cause them to be sick, not all children. And she's wondering if we could try turmeric and a gluten-free diet. So at this point, we're kind of at an impasse, and I recommended that the family pursue a second opinion because my concern is with the high eye pressure and risk for glaucoma that we're going to end up with vision loss if the child did not proceed with systemic treatment. So I gave them a list of uveitis specialists regionally and nationally, and the family elected to see Dr. Foster at Mercy in Boston, and he really has a robust website, so a lot of experience, and so I feel like a lot of my patients choose him for whatever reason, and he is very willing to get patients in. So I sent records and a letter to Dr. Foster. And then the outcome was that they were ready once they had this second opinion and a little time to digest. They met with the rheumatologist and me, and the family agreed to start methotrexate. She's had a partial response, and now we're escalating to Humira. So when I first went into medical school, I actually was interested in geriatric medicine, which is so far from pediatric ophthalmology, and I noticed how this whole process kind of correlated with a grief model. of Elizabeth Kubler-Ross, and how a lot of the things that my patient's family exemplified in these steps. So this disbelief and shock with the initial diagnosis or need for treatment, the fact that it seemed like that immunosuppression was a new idea despite our previous conversations. And then there was a denial component. They didn't think that the treatment diagnosis applied to them. And then Dad became angry. And he was pretty belligerent, but he was just scared. And then the bargaining, what other treatments are there out there? Can we do something different? Can we treat for topical steroids for life? I'm sure you've heard that one before. And then finally, a realization of the inevitable. And they're willing to seek a second opinion. They realized something had to be done. And then finally, seeking realistic solutions. And that led to a productive conversation with rheumatology and ophthalmology to arrive at the treatment plan. Now, some of the things that you may see in clinic, especially for the disbelief shock, may be that in addition to not remembering discussions, but the family may ask things multiple times, multiple ways, and you explain it multiple times, but they're just, there's just kind of a shock component. Denial may actually show up as non-adherence to follow-up. If I don't follow up, I don't know about it, then my child doesn't have this condition, and resistance to treatment. In terms of anger, patients may lash out at the provider or other members of the treatment team or system, whether it's wait time, scheduling issues, any inconveniences. That's just kind of a manifestation of the anger, kind of with the diagnosis. And then bargaining, families may look for non-pharmaceutical options, providers who give them a different answer, such as lifelong of topical steroids. And then finally, you arrive at realization of the inevitable and seeking realistic solutions. Now, anywhere along this cascade, you may have a repeat. For example, if a child is taken off immunosuppressive therapy after being in remission, and then the inflammation recurs, the cycle may start all over again. So what I try to do is I lay the groundwork for systemic immunomodulatory treatment on that first visit, even though they're, just each time kind of emphasize that this is normal, this is the normal progression to expect. Because the parents can't see the disease, I really try to educate with illustrations, online media, handouts. On our APOS uveitis page, there are actually a whole bunch of links to really good sources for uveitis, for patient support. And then it's not only the rheumatologist's job, but also the ophthalmologist's job to discuss systemic therapy, because they see the ophthalmologist more frequently, and they have built almost more rapport with you, especially if it's idiopathic. Try to reduce treatment myths, direct families to reputable websites, appointments. For patients with a new diagnosis or patients who are struggling, I usually have a secret 4 o'clock slot so that it doesn't slow down the rest of my clinic, but I just kind of say that, this is, take as long as it takes until the family has all their questions answered. And then if you're able to schedule rheumatology and ophthalmology together or sequentially, that's helpful, because then they're getting the same information either together or twice and kind of presents a unified front. One thing that we've found helpful has been connecting families with long-standing diagnoses with families with new diagnoses. And our hospital allows us to do this by having the family, I stay out of it, but having each family release their information through the sharing of information. The emails are shared, and then they can follow up with a telephone call or an in-person visit if they elect to do that. And then when you're not getting anywhere, empowering the family to get a second opinion is really, really helpful. I've done this a lot, especially with children with an idiopathic diagnosis, just because they don't see the disease, they don't see arthritis, and I go through, I discuss my concerns, complications at baseline, the development of new complications such as risk for glaucoma with ocular hypertension, and then the poor visual prognosis without systemic steroid-sparing therapy. I give them often a list of my colleagues, many of them on this panel, to seek a second opinion. And then if they also want to do it independently, they can go to the American Uveitis Society webpage to also get a list of specialists. All right. Anything you all would like to add? Or any questions the audience would?
Certainly, we have 4 kind of topic sections, and we'd love to answer questions sort of in between. There's no central microphone, but I think if you speak up, we can certainly answer any questions either now or all together at the end. So one of the things that we've noticed in our clinics is that Dr. Cooper and I have a clinic together, and the ability to have those conversations at the same time. And I've learned so much from her about systemic medications and risks and how to use them and what the parents' questions are, that actually as an ophthalmologist, that even if she's not there, I can answer a lot of those questions. And I think it really helps us to have the family feel like we're on the same team. And I know a lot of people don't have that option as a resource. But just being aware of what your rheumatologist is going to say and taking the time to invest in that relationship so that the family is always hearing the same thing, I think is really important. So like I said, Ashley Cooper is a rheumatologist. She's probably the only rheumatologist at the academy here right now. But we thought it was important because so much that's important in handling especially a child with uveitis